I'm Jason Shire, and welcome to Quick Gastro. This is a video on the internet, so we shouldn't be using this to diagnose or treat people with medical conditions. Read the fine print, but mostly this is just for education. Congratulations! You're a doctor, and for your next patient, she's pregnant. As a cis white male, I may not be the best person to tell you how everyone's feeling, but I can tell you how many people feel. When people learn that they're pregnant, particularly the first time, there are a lot of emotions that they go through. But being surprised or even scared is very common. And from that, people want to have some sense of control, so they often start to learn more about being pregnant. So they'll read books and topics and blogs and talk to people that they respect. In this process, there's a lot of good advice, but there's also some questionable advice. In fact, some people are very afraid of doing anything to the baby. Sometimes this helps because people stop smoking or drinking, but other times it leads to decisions such as stopping the medications. And this comes from a belief that the process should be natural, because somehow nature is good. But nature doesn't really have morality. And so Crohn's is as natural as things come, which means that given a chance, Crohn's and ulcerative colitis will come back. So then we come back to the doctor. The doctor's feeling all the same things that this mom is. The doctor is worried because what if I do something that hurts the mom or the baby? This is something that I'm not comfortable with. This is something that I don't typically see. And scene. So, where did this all go wrong? Well, two ideas. The first is the concept of primacy, and the second is the concept of what we're comfortable working with. Primacy is a neuropsych concept, and what it says is, whatever information we take in first, we're more likely to remember, and in addition, it will affect how we assimilate future information based on if it agrees or disagrees with the first information. An example would be if I first learned about the side effects of a medication and think that it's dangerous, it's going to be real hard to convince me that the medication is safe. This is why it's so hard to change someone's mind, whether it be medicine, sports, or politics. This gives us an opportunity to help our patients so that when they get pregnant, they don't have the fear and anxiety about the process. If the physician and the patient are comfortable with her being pregnant while having IBD and being on medications, that gives us the opportunity to experience one of the most rewarding aspects of all of medicine. So let's talk about some of the barriers to people having children when they have IBD. Did you know that both men and women with both Crohn's and ulcerative colitis have less children than the general population? There's several reasons that go into it, but the number one reason is they choose not to have children. A lot of people are afraid they're going to pass the disease on to their children. And while that's true that this is a genetic condition, the penetrance is quite low. I usually cite a 3 to 5% chance that somebody with Crohn's will pass the disease on to their child. If two people with IBD decide to have children together, that risk does go up, but it's still the minority of children born to those parents. They may worry that having a baby will make the disease worse, or conversely, that the disease may be bad for the baby. The short answer is that if the mom is in remission at the time of conception, she's most likely going to stay in remission throughout the pregnancy. Previously, we were taught that a third got worse during pregnancy, a third got better, and a third stayed the same, which sounds like we really don't know what's going to happen. What we can control is that if you get pregnant when you're in remission, we have better outcomes. In terms of the disease affecting the child, the two most common adverse events are either preterm labor or small for gestational age. Again, if the mom is in remission, it does not increase the risk of miscarriage. Another barrier is the concern that the medications can have an effect on the baby, and that's what we're going to talk about in a minute. Some people are worried about fertility, and that can be affected, but not to the extent that most people think. Your active inflammation, nutritional status play a role, medication side effects, and surgery can play a role, but these are usually reversible, and our role is to look for them. An under-discussed aspect is that people living with IBD, half of men and 3/4 of women, actually have body image issues. This can be related to scar tissue. It can be because you were diagnosed at a young age and it affects how you grew, so that maybe you're shorter or don't have as much muscle mass. Maybe puberty was delayed. It can be because medication side effects like steroids cause you to gain weight, retain water, have acne. But if you don't feel attractive and you don't feel interested in sex, it makes it much harder to start a family. Other issues that affect intimacy are dyspareunia, particularly if you have active inflammation in the perianal or vulvar area, along with depression, and just dealing with the symptoms of active disease. Now let's talk about medications, because ultimately that's what you and the patient are most worried about. For your boards, you just have to remember two medications. The first is methotrexate, and the second is tofacitinib. If a patient is on methotrexate, the standard of care is to have them on two forms of birth control. So for instance, a barrier contraceptive and IUD, or birth control pills, something similar. But does that apply to everybody? If a woman is a lesbian in a relationship with another woman, does she need to be on birth control? And the answer is probably not, but I don't have any actual research to explain that. Likewise, if she was bisexual in a relationship with a woman, then again, she probably doesn't need birth control, but there's no data to make that statement. And what if somebody is asexual? They don't enjoy being intimate with somebody else, but they can still get pregnant and they're in a relationship with someone of the opposite gender. We have no data on what to do for this population of people. So if you're interested in research, this is a good place to start investigating. This is the part people are going to want to remember when patients come in the office, so I'll include a link below. The first class of medications are the 5 ASAs. And by and large, they are safe to conceive on for both men and women. They are safe to continue during pregnancy and safe for breastfeeding. The issue here to remember is that sulfasalazine does require folic acid supplementation. Some women do flare during pregnancy, and so corticosteroids have a valuable role. Previous data suggested that they were associated with cleft palates in the first trimester, but subsequent studies have not shown that, so they're considered safe throughout pregnancy. The medication patients often worry the most about, because they can do an internet search, is the thiopurine. That's because this medication has a pregnancy category D, and while we don't use the category system anymore, that information is still available online. So what does that mean? Well, animal models showed that this medication was associated with cleft palates. But we've been using this for decades and have not seen that same relationship in our patients. So thiopurines are safe during pregnancy. And of note, a small amount does get into breast milk, but it doesn't have any clinical outcome. So we don't have to ask people to pump and dump when they're on a thiopurine. Anti-TNF are safe during pregnancy. Some medication does get across the placenta into the baby, and depending on the medication, maybe the concentration varies or is even higher in the baby than the mom. But there are no adverse outcomes, and they follow the babies for several years after they were born. They seem to do well. So there's no need to switch a patient who's stable on one medication to a different anti-TNF. The medications do get into the breast milk, but again, if they worked orally, we wouldn't give them to the patient's IV, so we're not too worried about that. The anti-integrin vedolizumab is considered safe during pregnancy, while there is limited data that natalizumab may be associated with complications. Anti-interleukin 12-23 is also considered safe during pregnancy and breastfeeding. And as a final reminder, methotrexate and tofacitinib are not appropriate for pregnant patients. Once the baby's born, there's still one more thing to do. We have to talk about vaccinations. And there are a lot of vaccinations in the first 6 months for a newborn. Remember that if they're on an anti-TNF, they still have medication in their system, so they're not supposed to get live virus vaccines. But there's only one vaccine they're not supposed to get, which is rotavirus. I try to tell my patients that you can tell a live virus vaccine because it's one that's given orally as opposed to a shot. So that's it. That's all there is to pregnancy and IBD. I mean, there's other little things, but this should get you through most of the issues. If you like this video, please feel free to share it with your peers. Be good to each other.